Welcome back to Meaning from Data, Statistics Made Clear. Every day, we make decisions about our personal health. It's one of the most important things that we think about, of course. And our state of health is often measured by data. And the kind of data that we are interested in are things like our weight, our blood pressure, the levels of our cholesterol and other various chemicals in our bloodstream. And these data present to us a picture of our well-being. So the kinds of questions that we're constantly asking ourselves about how to treat our own physical condition are questions such as, should we take vitamins? We don't want to get rickets. Scurvy is bad. We should probably take a lot of vitamin C. Should we take cholesterol-lowering medication? Should we take aspirin to reduce the chance of heart attack? That's a kind of a question. Or this is an important one, should we take Dr. Quack's super snake oil when we're just not feeling quite up to par? See, this is the kind of question that we need to make decisions on. And of course, a lot of the ways in which we make decisions in reality are that we use anecdotal information. That's one way. But sometimes our decisions are based on studies that have been conducted. And the way that we use the results of studies are that typically we read about a study and we compare the numbers that we have, our measurements of ourselves, compared to the numbers that were obtained in some study that involved a large number of people. And then that's what we use to make a decision. And for example, suppose that a study showed that on average, people who have a certain cholesterol level that's higher than a certain number suffer more heart attacks than people who have a lower such number. Well, if our cholesterol number is higher than that bad number, then our doctor may very well suggest to us that we take some cholesterol-lowering medication. And of course, the doctor will also tell us that we should eat more healthfully and exercise more. The doctor will always say that. Well, so what I would like to do is to look at a chart involving this issue of interpreting data about cholesterol in order to make a decision and discuss how it is that such decisions might well be made. Suppose that the data from this study about cholesterol indicates a chart such as this. And of course, by the way, this is just a summary. This is not a complete picture of the kinds of data one would get about cholesterol or other studies. So this is just for the purposes of our understanding statistics, illustrating a statistical principle, not for getting medical advice. So here's the kind of a chart, though, that might come about through a study about the levels of cholesterol. The study might involve 1,000 people. The sum of these numbers is 1,000, of which perhaps 500 of them have a low cholesterol reading overall, and another 500 of them have a high cholesterol reading overall. It may be that there are other tests, more elaborate tests, that allow a doctor to evaluate a risk factor for heart disease. So, for example, a sonogram, or injecting a radioactive dye into the blood system in order to detect whether or not plaque is building up on the inner parts of the arteries. So, using other kinds of tests, it may be that the doctor can evaluate the risk level for the different people in the study. So, and the kind of result would be indicated in this sort of chart. Namely, for the people who are in the low cholesterol group, below some sort of a threshold, it might be that 400 of those out of the 500 are at low risk for heart disease, and 100 are at high risk for heart disease, even though they do have low cholesterol. And on the other hand, for the high cholesterol group, perhaps it's the opposite, that 100 are in the low risk group for coronary disease, and 400 are in the higher risk group. So this is the kind of chart using which a person needs to make a medical decision. But actually, in evaluating these studies, we actually have to ask several additional questions. For example, how much higher is the rate of heart problems in the group that is indicated as having a higher risk. In other words, is it significant in the sense of being important, or is it just significant in the sense of being statistically significant, meaning that there's a detectable difference in the rate of heart disease, but it may not be an actually important difference. It's so small it may not be important, but it is detectable and real. So that's one question we need to confront. Another question that we need to confront is the question of how are the various effects distributed over the spectrum of people with different cholesterol levels. Meaning this, are people who are just over the threshold line of having too high cholesterol, are they at much greater risk than those with lower cholesterol? Or are they really about the same risk as people with lower cholesterol, and it's only people with very high levels of cholesterol that have significantly higher risks? Or alternatively, maybe the risk is fairly evenly distributed for people with the higher levels of cholesterol. There's sort of a threshold issue, and having more doesn't make it much worse. So those are the kinds of questions that we would want to know in interpreting the data of the studies. But there are other features that we'd like to know about the studies. Specifically, frequently, the studies involve a lot of people who are in many ways not like us. So they may have, say, a different weight relative to their optimal weight than we do. Or they may be of a different gender or a different race. It may be that their inheritance is different. That is, their parents may have had different levels of cholesterols and different profiles than our parents did. What we'd really like is to have a study involving people who are as much like we are as possible. Because you see, the reason for that is then we could be that the people would more apt to react to the interventions that are suggested or have the distribution of calamities that are portrayed. Those responses are more apt to be similar to how we respond if the people involved in the studies are more like we are. So let's do a specific little study associated with our cholesterol one. So let's look at a specific similarity that might be important in evaluating these cholesterol levels. One thing that we might like to know is how the study evaluates people who have the same HDL versus LDL profile as ours. Remember, HDL stands for high density lipoprotein, and LDL stands for low density lipoprotein. And the low density lipoprotein is the bad cholesterol, and the high density lipoprotein is the good cholesterol. So what we would like to do is to condition the overall study data on several variables, looking at the subset of the study data that match us with respect to those variables. Conditioning the data means just looking at those people who have the same condition as we do with respect to one or more of the different variables in the population. So let's see what we might see if we look at the overall cholesterol risk analysis, but we condition it on the levels of HDL to LDL ratio. In other words, we look just at those people in the population of the study who had, for example, a high HDL to LDL ratio. Well, first of all, for purpose of illustration, I just assumed that half of the people in the study had this higher HDL to LDL ratio. And notice what happens if we compare the data from this study conditioned on the high HDL to LDL ratio, in other words, having a lot of the good cholesterol compared to the bad. Notice what happened. For the low cholesterol, this is the low overall cholesterol group, the ratio of low risk to high risk people, which previously was 400 to 100, remained the same. The ratio was the same, 200 to 50. Whereas in the high cholesterol group, notice that the risk factor altered in proportion. Namely, notice that originally there was a 4-to-1 ratio of high risk to low risk, whereas in the in the case of just looking at the people in the population who have this, a lot of the better cholesterol, we find that the better cholesterol has somewhat mitigated the risk and left all of these 100 people who were in the low risk area are still having low risk, and a lot of people who previously were at high risk, having an overall high cholesterol level, no longer are there. So the point is that if we personally had a knowledge of our own cholesterol and happened to have this good high level of the high density lipoproteins, then this is the kind of a study that we would prefer to look at in order to make a medical decision about whether to intervene. Now, so the point is that we'd have a sense that the studies pertained specifically to us because they involved people who were like us in the important ways, in ways that we think are important to making this decision. So an intriguing possibility is to use the computational capabilities of modern computers to find people in scientific studies on which we could determine the efficacy of medicines, where we just choose those people in the studies whose characteristics are similar to our own. In other words, we would have the raw data of the statistical study and then perform a personal statistical analysis on that subpopulation. So, for example, on the effect of cholesterol-lowering drugs, we would tailor the study to our individual needs. And as we saw in the case of the HDL result, we might get a rather different statistical impression of the results if we based it on that subpopulation rather than on the whole population. And first of all, I want to say a couple things about this. First of all, in the case of HDL, it's standard practice now to use the HDL ratios as part of the discussion. But on the other hand, suppose that you're a child of parents who lived long and healthy lives but had high cholesterol. Maybe an analysis restricting to just those people would show a different concept about whether it's prudent to take cholesterol-lowering drugs. We don't know. So the point of this discussion is that conditioning data on a particular subpopulation is an interesting possibility. And let me repeat the caveat that all references to specific diseases and treatments and all data and interpretations are not to be viewed as medical advice. They're not correct. These were made up numbers for the purpose of illustrating a point, not for giving advice about cholesterol or anything else. Okay, so the goal here is just to think about statistical ideas. Okay, but the possibility of tailoring statistics to individual personal health situations seems to me that could conceivably provide a greater increase in personal health benefits in our society than would improvements in the treatments themselves. We know for sure that some ways that we deal with medications are simply wrong. For example, if you take a bottle of aspirin and you look at the dosage recommendation on the bottle, it says say two aspirin or something, completely ignoring whether the person is a 300-pound football player who's in his 20s or an 80-pound 100-year-old in a nursing home. And surely we can't really believe that the dosage for those two people should be the same. But of course people have to make these sort of generalizations. Now, and I admit in hospitals sometimes the dosages are varied depending on the weight, or in fact I think it's more the surface area of the patient. But and of course people respond to medicines in different ways. Some people respond very dramatically to little doses and some people don't. And each of us lies somewhere on a continuum of responsiveness to medications. And determining the right amount might be quite a different enterprise than the way that dosages are currently determined. So tailored statistics might lead to an incredible increase in personal health improvements. And maybe it brings up the prospect that maybe each of us will have to hire a private statistician to take the raw data from scientific studies and analyze that data to make the best inferences that apply to us. And maybe it'll be part of the doctor's procedures to look at such data. You can easily imagine that. And of course, doctors already are aware of how individual patients react. That's one thing when you get to know a doctor. To some extent, they do try to tailor their treatments to the individual, and they use their own experience and the details of an individual's case to modify the treatment. And of course, that's good. Using the doctor's experience is good, but it also is somewhat problematic because an individual doctor sees many fewer patients than there are in good statistical studies, and so may be biased by small sample issues that we've seen before. Well, let's look at another example associated with health decisions, and this is the following. Suppose we need to make a decision about what hospital to use, and we have some data about a hospital, and we're about to enter the hospital for some serious operation. So we decide to be prudent about this and look at the facts, and so we go to some database, and we see that there are 2 hospitals in our city that we could consider for attending for this serious problem. And we notice that these are the results. In Hospital A, of the last 1,000 patients who entered the hospital for this disease, 71% survived. And Hospital B, only 54% survived. Well, we might say it certainly seems clear from these data that Hospital A is the preferred hospital. Let's go to Hospital A. But wait a minute. Let's suppose that we look at the data broken down in a little more specifically into subgroups. So here we go. Here are 3 subgroups of different patients, the condition that the patients were in before they entered the hospital. So you see, we have, if for example, we're thinking about a person with a heart condition, they may enter in fair condition, serious condition, or critical condition. Suppose in Hospital A, most of the patients who enter Hospital A are in fair condition, which is the better condition, the least of the seriousness. 700 enter there, 200 are in serious condition, and only 100 enter who start in critical condition. Whereas Hospital B has a different profile of patients upon entry. Namely, only 100 who enter in the rather benign fair condition, whereas 700 enter in critical condition. Now we could have data about all 3 of these subpopulations. And look what happens in these subpopulations. For those who enter in fair condition, in Hospital A, 600, that is 86%, survive, whereas in Hospital B, those among the 100 who entered in fair condition, 90, or that is 90%, survive. Those in serious condition, 200 in each hospital, but only 100 from Hospital A survive, 50% rate, and 150 from Hospital B for a 75 recovery rate. And then for those who enter in critical condition, only 100 enter in Hospital A, but only 10 of them survive. That is to say, only 10% of the critical condition patients for Hospital A survive, whereas 43% from Hospital B survive. The overall effect is what we had before. We didn't change the absolute numbers. But by looking at these subcategories, we see that in fact, Hospital B actually has a higher success rate on each of the subpopulations, suggesting that it's actually Hospital B that's the hospital that you should consider in this serious condition. Now, and by the way, this might be the case if Hospital B is say a teaching hospital or a research hospital that gets the more serious cases. So this is an example of that we actually have seen before, and that is Simpson's paradox. Remember, we saw it before in lecture 13 when we saw the gender discrimination case and how the view of that gender discrimination example switched when we broke down the case into the subcategories. Well, okay, so let's move on to another question that we need to answer when we're trying to make health decisions. And that's a question that arises when we're trying to distinguish between a quack medicine and a real medicine. And there's a comic line which says the following. It says, if you take this cold medicine, you'll be well in 7 days. If you don't take it, the cold will linger for a week. So this is a possible outcome of taking a medicine. But to determine whether a medicine works, we should compare it to no medicine at all or to a placebo, as we've discussed before in double-blind experiments. We did this before. But it turns out that there's a good reason why quack medicines work. Namely, people usually recover from minor diseases without any intervention, without any medicine. So if you're ill and you take a medicine that has no effect whatsoever, it's likely that you'll get better. And so if you interpret this happy result as an effect of the medicine, what will you do? You'll tell your friends and your neighbors, and soon a new medical miracle will be upon us. And in fact, of course, the medicine may have had no effect at all or may even have impeded the healing. So quack medicines appear to work because of a phenomenon called regression to the mean. Let's think about this. If you have a baseline health profile, you're usually at a certain level of health. If you get ill, then you're going to expect later to return to your baseline, to return to your average. And so suppose that we perform a statistical analysis of a totally bogus medicine and see what happens. So, and the treatment consists of giving the medicine to a person who has, say, a cold, and then seeing whether the person is well in a week. Suppose we just try that. Well, the result will be that we'll get a statistically significant result that more people are well after the week than they were when they started. But it would be wrong to interpret this as an effect of the medicine. And here's a chart that might indicate what I'm talking about. So here is our, let's suppose that these dots represent a sort of random scatter of how you feel from day to day. And the baseline is this horizontal line in the middle, and you sort of randomly feel better or worse from day to day. Suppose on the days that you feel particularly bad, such as this day, you take the medicine. Then look what happens just by randomness. You see all of the 6 dots, which are the subsequent dots in the week, are higher than where you started. And this would happen if we look at a lot of these dots here where you're sort of on the very sick side, you tend to be better afterwards. This is called regression to the mean. By the way, there's another example of regression to the mean that's sort of interesting, having to do with child rearing. And some people who have reared children sometimes have the impression that what we say to our children has no effect whatsoever on their behavior. Now, so let's just assume for a moment that this is true, and look at a statistical analysis that might lead us actually to a different conclusion. So suppose that every time the child does something especially good relative to that personal behavior, we praise the child. It's a perfectly natural thing to do. And suppose that when the child does something that's particularly bad, we punish the child. Let's see what happens. In each case, and once again, let's assume that neither praise nor punishment has any effect whatsoever on the child, okay? Well, let's see what happens. The child will tend to return to his or her average behavior. And that's what it means. That's the definition of the average behavior. So if something deviates to below its average, it'll tend to come back to the average, and if it's above, it tends to go down. So when we interpret this effect of praise and punishment, let's think it through. If the child is better than average and we give the child praise, what happens? The next thing that happens is the child returns to average, that is, gets worse. And on the other hand, if we punish the child who is behaving worse than normal, what happens? Just by no effect at all, the child tends to return to his or her average, and therefore it gives the impression that punishment works. So it's similar to quack medicine. In both examples, it's that something appears to have an effect, but the actual explanation is regression to the mean. And by the way, this occurs in all sorts of areas. Once you get attuned to this concept of regression to the mean, you see it everywhere. Athletes who appear on the cover of Sports Illustrated tend to do worse right afterwards. Why? Well, why are they on Sports Illustrated? Because they did something especially good. And what's going to happen? They're going to return to their more average behavior, which means to get worse. So there is in fact a well-known sort of curse of being on the cover of Sports Illustrated. If you install a camera at a dangerous intersection where there's been a spate of accidents, then what happens? Fewer accidents will happen. Why? Because it'll return to its average. And if you think of the opposite, if you put a camera at an intersection that has never had an accident before, then it's sure to have the effect of causing an accident. If ever an accident happens, you could blame it on the camera, you see. So these are all examples of regressing to the mean. Another example is the children. Children of tall people, on average, tend to be shorter than those people themselves. And children of short people tend to be taller than the parents. But they're regressing toward the mean of the overall population. So this is, I think this regression to the mean is really interesting. Well, let's now turn to one of the most common issues in the realm of personal health management, and that concerns dieting and weight. And many of us have dealt with the problem of keeping our weight at the correct level. And I'm going to use me as an example. So now, it used to be that I would play racket sports very vigorously 4 or 5 times a week. And we would play squash and racquetball and tennis and so on. And my opponents, we'd play so vigorously that we had the rule that a victory wouldn't count unless you could make it to the car under your own steam. That was just one of the rules of the game. So you always had a chance, even if you lost. It sort of gave you hope. But what happened is that I overdid these racket sports, and my knees gave out, and so I was unable to play racket sports. But I discovered that I was still able to eat at the same rate as before. And in fact, my eating habits are illustrated by this sweatshirt that some friends of mine gave me that sort of give an indication of my eating habits. It says, I don't know if you can read it. It says, "Life is uncertain, so eat desserts first." You see that? And from my point of view, eating desserts first did not necessarily mean you wouldn't also eat them after the meal. You understand? So it was just eating all the time. Well, in any case, after I quit playing these racket sports, I discovered that after a certain amount of time, I was about 15 pounds heavier than I had traditionally been. And so I started taking a weight chart, and every morning I would weigh myself and keep a record of this weight. And the reason I want to bring this up is that the question of how much do you weigh sounds like such a simple question. But as a matter of fact, it's not a simple question. What does it mean that you weigh a certain amount? During every individual day, you gain and lose several pounds. The range is several pounds for every day. So one way to take a weight is to just keep one weigh yourself in the morning. So what I did is I'd weigh myself before breakfast every day that I was home and that I'd remember. I would put a dot on this chart. And the dots on the chart would indicate the reality of my weight. It's not just a single number. It's actually a distribution of numbers. So during a period when I really weighed the same, when I wasn't gaining or losing weight, the kind of chart that we would see is a chart like this. We would see a scatter of points, not just, they won't all be the same, but in fact there'll be a scatter of points that somewhat cluster around a mean value. And so the best description of one's weight would be the mean of those collection of weights. And by the way, this is called a time series, meaning that at every day or at every time you take a value, and that's a time series. And you can see that in days where there's a gap, you would just have a gap and no dots, and then there would be other dots when you get back to weighing yourself. Oh, by the way, this is a histogram of the weight measurements during a period of time. And you can see this is what you'd expect, that you'd expect the weights to be hovering, having probably some sort of a somewhat normal distribution centered around a single value. If you want to know whether or not you're actually losing weight, what you should do is take one way to do it would be to take a time series where for every day you put your weight weighed, say, in the morning, And if you found that there's a correlation that is statistically different from zero between the days and the weight, and if the least squares regression line has negative slope, then that would be an indication that you are indeed losing weight. A lot of weight loss programs, by the way, tell you only to measure once a week. But I think the reason for that is that they think they're not working with people who are sophisticated at interpreting statistics, because people who understand that there's going to be variation and that we're just looking at these cloud of points and summarizing them by a regression line would actually get better data by taking more weights per time. So it's been my pleasure to talk to you about some issues about personal health, and next time we will take on the topic of economics.